All right, congratulations. We have made it to the type 4 hypersensitivity. If you've been following this video series, so far, this is actually probably going to be one of the easiest hypersensitivities to understand because we've talked about this mechanism so many times that at this point, it should be pretty much review in terms of T cell activation component. And again, the thing is that I'm kind of referring to here is, when we talked about type 1 hypersensitivity, we were talking about IgE antibodies. When we talked about type 2, we were talking about, IgG, maybe IgM binding to the surface of cells. Type 3, we're talking about immune complex formation, IgG being very classic. But you can see in all these situations, we're talking about an antibody. We're talking about some kind of humoral response, right? But in type 4, it's kind of in its own world over here, in the sense that this is primarily going to be T cell mediated, and it's going to be more, like we said, cell mediated response because we have T cells involved. So it's a little bit different in that sense. It's not necessarily humoral. There's no antibody that's classically going to be kind of potentiating this pathway. Okay, just to clean things up here a little bit, let's just go through an example of this. So allergic contact dermatitis is kind of like the poster child for this. And when we're talking about this, there's a few different causes, right? Poison ivy's one, latex, nickel. Let's just go with poison ivy here and we can kind of go through a demonstration. So, poison ivy, our patient, this is the surface of their skin, right? And they're having some exposure to poison ivy. Maybe they were outdoor camping, which would be very classic. Whatever the case may be, this patient was exposed to poison ivy. Okay, so this patient was exposed, and this chemical that's released here, this is urushiol. Okay, and this chemical is very classic for causing some of these symptoms. Now, urushiol is actually a hapten, is referred to as a hapten, and essentially what that means is it can bind to proteins and then have that protein with the hapten presented to these antigen presenting cells that we see here. And so, if we're talking about the skin, what kind of antigen presenting cell we're going to have here? Well, primarily probably Langerhans cells. And those cells will find these antigens and bind to them, right? So they'll bind to their corresponding receptor, binding to the epitope. And of course, this is the same thing that we've been talking about, from day one, watching these videos, right? So the antigen presenting cell is going to present that antigen on MHC2 to a CD4 positive T cell, right? And then that CD4 positive T cell with the matching T cell receptor, CD4 positive co-receptor, will bind to that antigen. It will get activated, right? And then this antigen presenting cell will activate it using interleukin 12, right? Interleukin 12 will be used to activate the CD4 positive T cell. And then this CD4 positive T cell will then form a T helper 1 cell, again, because it was stimulated with interleukin 12. And then that T helper 1 T cell will then go on to release interferon gamma to activate antigen presenting cells, particularly macrophages, to release chemicals at the site of the urushiol. That's where that inflammation is going to be. So again, same concept we talked about. It's literally just the T helper 1 response that I'm referring to here. The important point though is you have to know, is this the first exposure or re-exposure? This is something that we keep kind of going back to. On initial exposure to this antigen hapten complex, the antigen presenting cell, like we said, will present to the CD4 positive T cell, binding via MHC2, interleukin 12 stimulates differentiation to a T helper 1 cell, and then that T helper 1 cell will release interferon gamma. That interferon gamma will essentially stimulate macrophages. However, on that initial exposure, this isn't going to tend to be as dramatic as subsequent exposures, right? The memory response is going to be much greater. So if I'm exposed to this again down the road, I'm going to have preformed T cells that are ready to go in this tissue the next time I get exposed to urushiol. And in that situation, I'm going to have a lot more interferon gamma released from those T helper 1 cells, meaning there's going to be a lot more macrophage activation, meaning that this inflammation is going to be a lot worse, right? That's the idea. I'm going to have more interferon gamma release because I have more preformed T cells, because I generated a memory response, right? Because I generated a memory response. That's the key. So subsequent exposures will be worse. It's kind of like what we talked about with the type 1 hypersensitivity, different pathway though, right? And so again, we'll generate an inflammatory response. And the other thing is, remember, these antigen presenting cells, right? So let's just kind of clear some of this up. These antigen presenting cells here that are binding to these proteins, these haptens, if they're binding them up or if they're phagocytosing something to present them, then they're going to be on MHC2, right? Remember that. So if you're phagocytosing something, if it's an extracellular antigen, it's going to be on MHC2. However, remember that all of our nucleated cells have MHC1, including the antigen presenting cell. Now, the antigen presenting cell will usually only display antigens on MHC1 if it's infected with them. Like if there was a virus, for example, a virus could infect an antigen presenting cell, cause it to then be presented on MHC1. And remember, if you present on MHC1, the cytotoxic CD8 positive T cell can then get activated and destroy it. In this situation, urushiol isn't necessarily infecting the antigen-presenting cell. So pretty much the antigen-presenting cells will just present on MHC2. However, there is urushiol that's going to be in close contact with some of this epithelial tissue. These epithelial cells can potentially present on MHC1. That MHC1 presentation would cause activation of CD8 positive T cells, eventually cytotoxic killer CD8 positive T cells that would then release perforins, granzymes to cause inflammation to the tissue here. In fact, a lot of the inflammation and tissue damage you see here on subsequent exposures is because of the CD8 positive T cells that are ready to go from this memory response to wreak havoc and damage at these sites that are exposed to the urushiol. Okay, so again, key points here. Number one, it's a T cell response. Memory response is a much higher on subsequent exposures, similar to what we talked about with type 1 hypersensitivity, even though this is a different mechanism, right? It has to do not necessarily with the class switching of antibodies, it has more to do with a memory response of preformed T cells that are ready to go in response to these antigens, generating larger quantities of interferon gamma, more macrophage activation, more cytotoxic killer T cells that are ready to go. And again, also remember, all of this interferon gamma is going to cause your acute inflammatory response. The key 3 cytokines to remember for that were TNF alpha, interleukin 1, interleukin 6, right? So that's where you can get fever potentially from this. You can get some edema in this area, right, as you get fluid leaving this area because of this inflammatory cascade. And remember, kind of 2 divisions here, right? You have your T helper 1 response, you have your cytotoxic CD8 positive T cells, all of this being cell mediated. And that's why before I kind of said that the T helper 1 response is in some ways part of that cell mediated cascade. Okay, and the only thing I think I skipped on here was this interleukin 2. Just remember, these T cells that when they get activated, interleukin 2, remember what it's responsible for. It's basically responsible for T cell growth. It can be autocrine, paracrine, endocrine, right? It can stimulate T cells anywhere. Even the T cell that releases the interleukin 2 can then get stimulated by the interleukin 2 it released. With that being said, CD8 positive cytotoxicity is a big factor in a lot of these situations. Like I just said here, right? CD8 positive T cells can wreak a lot of havoc and cause a lot of damage simply from releasing perforins and granzymes on subsequent exposures. In situations like MS, we're targeting oligodendrocytes, right? Inflammatory bowel disease, type 1 diabetes, we're targeting the pancreatic cells. Hashimoto's thyroiditis. Remember, Graves' disease, if you're comparing the two, Hashimoto's being hypothyroidism, Graves, you're thinking hyperthyroidism. Graves' disease is a completely different mechanism, right? We're not using CD8 positive T cells to destroy thyroid tissue in Graves' disease. In Graves' disease, we're essentially going to be taking antibodies to bind to the TSH receptor to stimulate it to cause more thyroid hormone to be released. So again, that you have to understand the mechanisms here. If you understand the mechanisms and how all of this works, you're going to get a lot more questions right than if you're just trying to memorize where things fall, right? You have to kind of understand what's happening. In this situation, we're literally just destroying thyroid tissue as opposed to stimulating a receptor that causes more thyroid hormone to potentially be released. And again, CD8 positive T cells primarily will be binding to MHC1. Remember, almost all of our nucleated cells are going to be displaying this. If T cells recognize something on MHC1 that's foreign, they'll destroy it, right? If it's on oligodendrocytes, if oligodendrocytes are foreign to our T cells, if our self-tolerance isn't preserved, so to speak, through those initial steps in negative selection, right? If that wasn't effective, or if we have a poor T regulator response, we might be targeting our own tissues. Okay, and these are all things that we've talked about already. And how are we doing that? We're doing that by having CD8 positive T cells bind MHC1 on our nucleated cells, particularly in the case of MS, oligodendrocytes, pancreatic tissue, thyroid, whatever it may be. I put a little bit of skin differential on here. The only thing, I really want you to take away from this is going back just because we're talking about the skin. I don't want to make this like a derm lecture or anything, but just know allergic contact dermatitis. We talked about the big 3 on here. Dress syndrome is drug rash and eosinophilia with systemic symptoms syndrome. I know it's a mouthful. Really, the big thing for this is a patient that was just started on allopurinol. That's like the classic drug. Doesn't have to be allopurinol, and allopurinol can be seen in hypersensitivity reactions, etc. But the point is with DRESS syndrome, when you're comparing it to some of these other pathologies, DRESS syndrome is very classic for happening, 1 to 7, 8 weeks after you start the drug. So it's going to be sometime after you start the drug, a few weeks after, and the patients will have eosinophilia, just like the name says, right? You have the E for eosinophilia. They'll also have variations in the platelets and the lymphocytes, right? I don't want to go into all the details on that, but just something to be familiar with. We're talking about the different medications here. So allopurinol for DRESS syndrome. And then when you're thinking about SJS and TEN, which you can also see allopurinol with, but the big 2 drugs I want you to remember are going to be lamotrigine for SJS and TEN. And by the way, this is Stevens-Johnson syndrome and toxic epidermal necrolysis. And you can check out our derm videos for, a really good explanation on this, but I don't want to get too off track. But lamotrigine is one big one. And then the other one is trimethoprim sulfamethoxazole. So these 2 are going to be very classic for causing this syndrome in particular, or at least putting patients at some degree of risk. I also put phenytoin and carbamazepine on here just because, like lamotrigine, it's kind of like that whole anti-epileptic category. It can get plugged into that SJS-TEN profile. So just something to keep in mind. But particularly if you see a question about lamotrigine or trimethoprim or sulfamethoxazole, just keep that on your radar. Okay, the last thing I want to talk about on here is going to be the tuberculin skin test and the Canada skin test. And so just remember what we're talking about here is we're talking about injecting some antigen, right? So we're injecting some antigen. And if I've had exposure to this antigen before in the past, then I'm going to generate a response, right? I'm going to have antigen presenting cells, same pathway we talked about, activating our T cells. You know, if I've been exposed to this before, I'm going to have pre-formed T cells that are pretty much ready to go, okay? In fact, there could be T cells that recognize this antigen directly in certain situations, but a lot of times there'll be an antigen presenting cell initially kind of surveying this area, presents it to a T cell, and these T cells are ready to go. We're going to have a memory response. So we're able to generate, a relatively fast response within, 48 hours or so, where these T cells can then cause, right, cytotoxic T cells, CD4 positive T cells with activating macrophages can cause there to be some induration that forms here. So we're just going to call this an induration. And this basically shows that we had been exposed to whatever antigen we injected into this patient, right? It shows that we've had a previous exposure. We were previously exposed to that antigen. And this, again, is very gross oversimplification. I think we went through the pathway a little bit more when we talked about the Canada skin test, but it's the same pathway that we've been going over this whole time with T cell activation, T helper 1 response. Okay, the point is it's a cell-mediated pathway, okay, and you need T cells. You need T cells for you to generate this induration. You can imagine if I took out these T cells, I wouldn't get the induration here. Okay, that's the point. All right, so you need T cells. So let's just go through this. So the first thing, I'm gonna start here with the Canada skin test. If I gave a patient a Canada skin test, what would I expect to happen? So let's just say that here's a healthy patient, okay? Here's a healthy patient. We'll just draw a smiley face here. So this patient's healthy. This patient, if I did the Canada skin test on them, okay, I'm just going to put C test here for Canada skin test. If I did the Canada test, what would I expect to happen in a healthy patient? Would you expect to get an induration of some size, right? The answer to that is yes. You would expect there to be an induration because the patient should have been exposed to Canada. That's number one. They should have been exposed. You might be saying, well, how do I know this patient was exposed to Canada? Well, almost everybody is exposed to Canada at some point, right? It's a superficial skin infection. We just don't see Canadal infections because our body's able to fight it off. Okay, so but most people have been exposed to Canada. And so in a healthy patient, you would expect there to be an induration. Now, what about a patient, on the other hand, that's not healthy? Okay, so maybe a patient specifically, let's say this patient has SCID. Okay, so this patient has very low levels, if any, T cells, or maybe it's an AIDS patient, right? So this patient, we're gonna put no smiley face right now. So this patient is not happy, right? And so if I did the Canada skin test on this patient, would I expect to get an induration? And the answer to that is no. You wouldn't, because you don't have functioning T cells. If you don't have functioning T cells, because you can't go through a T helper 1 response, you can't have CD8 positive T cells attacking that area to cause there to be some inflammation to get the induration. Okay, so that's the point. Let's add a layer to that. Now let's talk about the tuberculin skin test. So now if I did a tuberculin skin test on a healthy patient who does not have TB, okay, would I expect an induration? And the answer to this is no, right? You wouldn't expect an induration if my patient was healthy and my patient did not have TB. Now let's say that I had a patient that is not healthy, right? And this patient also does not have TB. So this patient's not healthy, but they don't have TB right now. Okay, now let's say in our patient that's not healthy, this patient has SCID, for example, right? But this patient also does not have TB. Let's say I do the tuberculin skin test in this patient. Would I expect this patient to have an induration? And the answer is no, right? It's for the same reasons as the Canada skin test. It doesn't matter what T cell tests I do. In any case, this patient will not have an induration because they don't have T cells. Okay, not because they don't have TB, but because they don't have T cells. Okay, now what if these patients actually had TB? Okay, so let's do T test and then we'll put yes, TB. What if we did the T test and my healthy patient actually had TB? what would happen? So try and think about that. So if you had a healthy patient that has TB, what should happen on this test? Well, the T cells are working, right? And this patient has been exposed to TB. And when I put yes TB, I'm saying the patient's been exposed to TB at some point, right? They're previously exposed. That could mean that they have a current infection, they've been previously infected, right? Or maybe they even got a vaccine, like a BCG vaccine in the past. So they've had this antigen exposure in the past, right? So in this situation, if this patient had been exposed in the past, what would happen if I did the tuberculin skin test? Would I expect an induration? And the answer is yes, you would, right? Because you've been exposed to the antigen in the past and you have T cells here that are essentially functioning, right? So in this situation, we would expect there to be some response in my healthy patient, even though this patient's healthy in the sense that they have T cells, they are infected with TB or had previously been exposed, right? It could be either one, but they would generate an induration in that situation. Now, what about my not healthy patient? So again, we do the T test and we're saying, yes, this person has been exposed to TB. It could be an active infection, could be a previous exposure. Would I expect this patient to have a sizable positive test, right? A positive induration? And the answer is no, right? It doesn't matter what this patient actually has, what exposure they have. And why does it not matter? Because they don't have T cells. If you don't have T cells, no matter what, you can't generate the induration, right? If you have SCID, if you have AIDS, you're going to have a problem in these situations, okay? So that's why they have to sometimes change the parameters of what is a positive test in patients that are immunocompromised. In a healthy patient, we would expect whatever this patient has in terms of exposure should be semi-accurate. And so what you can do in these patients, right, if you're not sure what the patient's T cells are like, you don't know if there's any anergy, right, in this patient, you can do a Candida skin test and a tuberculin skin test. So the Candida skin test, right, will just tell you if this patient has functioning T cells. You are expecting an induration, right? Are the T cells functioning? That's the question that the Candida skin test is going to answer, because everyone, more or less, should have been exposed to Candida. The tuberculin skin test, on the other hand, is going to answer, does this patient actually have TB? Okay, but you have to look at these together, right? So if you have a negative TB test, but you also have a negative candidal antigen test, well, that's not very helpful. That tells you that this patient might just be immunocompromised. That doesn't tell us if this patient has TB or not, right? It just tells us that this patient is probably immunocompromised. And so you're essentially using the Candida skin test as a control, okay? So this is where a lot of these questions come in, where you have to understand what's going on. You can't just sit back and memorize all this stuff. It'll be pretty difficult. If you understand the principle behind each of these tests, the point is, if you've previously been exposed to an antigen, you generate an induration here. The key of that is that you need to know that you need T cells to generate that response. So you have to weigh in, has this patient been exposed, and do they have functioning T cells? And all of that has implications into your results.